Welcome, everyone. My name is Ann Zizet, and today we're going to talk about coding injuries in ICD-10-CM. I am an independent consultant, and I do specialize in ICD-10-CM and PCS coding. So let's get started. So the objectives for today's webinar will be to review those ICD-10-CM guidelines specific to Chapter 19 and 20, and specifically pertaining to injury. So there are other guidelines there, such as for poisonings and such, but we're going to concentrate on the injuries. And of those guidelines, we're going to concentrate specifically on any new guidelines that we saw in 2015, and concentrating on the seventh characters primarily. And then certainly after we look at the guidelines, the fun part then is to learn how to apply some of those guidelines. And we'll use some various scenarios and cases to do that, and then also looking at some potential documentation gaps in our clinical documentation when coding injuries. So let's get started, and as I said, we're going to begin with the guidelines. And on your slides, you'll note that some of the font is in bold-faced font, and that would indicate that the changes were seen in the 2015 guidelines. Some of the code books that were published for 2015 had the updated information, but they did not understand that there were going to be guideline changes. And so in the beginning part of your code books, in some particular editions, you may not find the 2015 guidelines. And this is where we had some significant changes, if you will, to the injury chapter and to the external cause codes. So you'll want to make sure that you have a copy of those guidelines with the bold-faced font. Interesting that 2016 has no changes in these two chapters, so the information that you will glean today will still be appropriate when we actually go live this October. All right, the changes were made, as I said, to the 2015 guidelines pertaining to the seventh characters, and the concept of new physician has been deleted, and it's been replaced with some new terminology, and you'll find that in that bold font on this particular slide. Now, we know that most categories in Chapter 19 and really all of the codes in Chapter 20 will require a seventh character, and those seventh characters for initial, subsequent, and sequela are listed in this particular guideline. And then new to this guideline will be that when the patient is seen by a new or a different provider over the course of treatment for an injury, the assignment of the seventh character is based on whether the patient is undergoing active treatment and not whether the provider is actually seeing that patient for the first time. So the word new, as was presented in the previous guidelines, turned out to be somewhat challenging for the coding process. So hopefully this new terminology assists in the assignment of those codes. Moving on to some additional information about those seventh characters. A indicates initial encounter, and that's used while the patient is receiving active treatment for the condition. And we have some examples here. So certainly surgical treatment, emergency department encounters, and then evaluation and continuing treatment by the same or a different physician. And you can see that new terminology on this slide as well. I like to replace the word initial with the word active, and I'll talk about that as we progress through these slides. The subsequent encounter is going to be utilized when that patient has already received their active treatment and is now just in the routine healing or the recovery phase. So if you can really key into those key words, it will help you understand what we're talking about with subsequent. They added one new additional example here, but things such as cast changes or removals, x-rays, of course, to check for the healing status of a fracture, removal of external or internal fixation devices, just managing the medication, and then any other aftercare or follow-up visits, such as physical therapy. Now, the aftercare Z codes should not be used for aftercare for conditions such as injuries or poisonings, or where those seventh characters are provided to identify subsequent care. And this is a guideline, and it's an important guideline. And I like to replace that word should never be used for aftercare of conditions such as injuries. They do give us an example in the guideline, and I just wanted to point out some things that we'll talk about later, and we will do a few examples that were taken from the first quarter 2015 coding clinic. And really, that issue was quite heavily weighted toward the appropriate use of seventh characters. So I really think everyone should carefully review that issue and digest the examples of the correct use of the A, D, and S seventh characters. And when they say in coding clinic and in the guidelines that no aftercare Z codes should be used for injuries or poisonings, they're really serious about that. There was even an example about suture removal, and they tell us not to use the Z code for suture removal when it's related to injuries. So, and one more word of caution, I've seen some articles that have been published by various authors, and I know that people get really excited about some of those Z codes that are in that last chapter, chapter 21, and then they say, oh, wow, there's this great code, for example, Z47.1, which is aftercare following a joint replacement surgery, and they get really excited, as I said, about that code and want to use that aftercare code. But remember, we can't use it if we are talking about an injury, if it's involving an injury. That would really go against the coding guidelines. So yes, that code is available, the Z47.1, and you can look that up in your code book. It's for aftercare of a joint replacement. But if the patient had a joint replacement done for arthritis, which is a medical condition, then of course that code is going to be appropriate. But if they had a fractured femur, then that Z code is not appropriate, and we would turn to our seventh characters to show where we are in this encounter. And also remember that the concept of rehab as we know it in ICD-9, the V57 codes that we probably use a lot, that whole concept has been eliminated now in ICD-10-CM. So injuries are reported with the appropriate seventh character, as we said. Now moving to the third type, and that is the S for Sequela, and that would be used for any complications or conditions that arise because of an accident or an injury. And a very good example is a formation of a scar after a burn. I think that's one that a lot of educators use. So the scars would be the sequelae of the burn, and then with the actual burn itself, we would code that injury code. We would assign the S to show that the precipitating factor of that. I'm sorry, I misspoke there. And then the S is added only to the injury code. So that makes sense. We're adding these seventh characters onto the injury code. So the S does not go to the sequela code, but rather to the injury code. And there is a specific way that we sequence these. So the specific type of sequela, and our example was a scar, would be sequenced first, and then it's followed by the injury code. Now, this slide just is talking about fractures and how specific the data or information can be with fractures. And so here we get into some of the documentation issues that I talked about earlier. So the actual type of the fracture, certainly the specific anatomical site, whether the fracture is displaced versus non-displaced, can be captured in these code assignments. The laterality now is a new issue in ICD-10, so we can identify the right and the left side. And then things that we are used to, such as delayed healing or routine healing and non-unions and malunions, certainly can be captured, but I think you'll see they're captured in a slightly different manner. And then the types of encounters that I already talked about, the initial, subsequent, and sequela. So let's move on and we'll talk more about these concepts. Now for fractures, in addition to the A, D, and S that we already talked about, we have some additional options for fractures. And here's where we can show if it's an open fracture, and then that subsequent information that I talked about with routine healing or delayed healing, and then non-unions and malunions. Also in ICD-10-CM, we have the ability to show some additional information about open fractures that are of the long bones. And they would specifically be for categories S52, S72, and S82. And that's called the Gustilo Open Fracture Classification. Now, this is a fairly well-known classification system that orthopods use to capture the severity of the open wound of those open fractures. And we'll talk some more about that on the next slide. Now, we also said that all fractures can be categorized where it's appropriate as displaced or non-displaced. Some fractures, like vertebral fractures, have a different classification. So as I said, where it's appropriate, primarily all of your long bones would be categorized to displaced versus non-displaced. And you can see on the slide that there is a default, and that is displaced. A fracture not designated as open or closed, just like we know in ICD-9, is coded to closed. Now, I do want to talk about this slide in a little bit more detail. And what I want to tell you here is that in this coding process, when we're thinking about displaced or non-displaced, the coder could be doing everything correctly. They could be following the guidelines. They could be following the index, certainly your encoder, and coding all of your fractures to displaced if you don't have that documentation. But I do want to caution you about that. Because when we learn about PCS procedures, there's a specific way or a special way that we code a fracture reduction. And that root operation in PCS is reposition. And the guidelines there tell us that that's only used for displaced fractures. Because if we think about it, we're not going to reduce a non-displaced fracture, right? We would probably do something to it. We may put on a cast or use a splint, maybe even have to do some internal or external fixators. And that's all okay. And in PCS, that's how we code those kinds of fractures. Non-displaced fractures are coded to exactly what was done. So I just want to caution you about how our diagnosis and our procedure should really match up. It would be very problematic if we would code the diagnosis to displaced, but then code the procedure as not doing a reduction and just putting on a cast. So certainly I would make sure that you work very diligently with your radiologists and your orthopods in order to get that great documentation that we really need to code these correctly. Now, this slide does list some of the information about what a Gustilo classification is all about, and we can see different categories here. So there are actually three main categories. The first category is a low energy wound, less than 1 centimeter. Category 2 or type 2 would be greater than 1 centimeter with a moderate soft tissue damage. And then category 3 or type 3 would be more severe injuries. And you can see that they're subdivided into 3A, B, and C. Now, when we move down to, for example, 3B, where we see inadequate soft tissue cover, the procedures that they do on these patients would be, muscle flaps or grafts, skin grafts, or, they have to cover the tissue. The 3C injuries are very extensive injuries, and these patients may be undergoing amputations. So this classification is important. It does identify severity of that patient. It indicates their prognosis and what kind of treatment they're going to have. And I really would like for you to watch for that documentation from now until October 1st and see if you can find it in your record. And I know a lot of people say, well, I don't think it's in our records. But it's most likely not in your x-ray report. But look at your surgery reports. And I've seen many, many records and orthopods that document this. And they'll say it's a type 1 or a type 2 as they're dictating or doing that op note. So be aware of that and be watching for that. It's certainly something that you could put on your documentation improvement list to work toward. This guideline was also new. It's part of 1C19A as well, and it was just added to help us understand the 7th characters when we're talking about complications, because when we're actually treating a specific problem, such as an infection or an inflammatory reaction, some folks got a little concerned about examples listed here when the joint prosthesis was inserted, many years ago or a time ago. And so what 7th character do we use? And this guideline is to tell us that if we're giving active treatment now, we're going to use that A for the 7th character. Now we're going to move to the guidelines and focus on some of the guidelines in Chapter 20, and specifically the Y92 for place of occurrence, the Y93 for activity, and then we'll learn how many of these are used together. And so hardly any of these Y92, 93, or 99 codes stand alone. They're intended to be utilized together and then also with the main external cause code. So let's move on. The first guideline, I1C20, is for external causes of morbidity, and the bold-faced here is important. We know this from ICD-9, so here's something that is totally the same. We never list those external cause codes in the first listed or principal diagnosis position. And these codes are intended to provide data for injury research and evaluation of injury prevention strategies. Now this slide, I did bold this font, but it really was something that was new in 2014. But I do think it's important, and it was a fairly new change, so I wanted to make sure that you read this in its entirety. It is specifying for us that there is no national requirement for mandatory external cause code reporting. Some states do have a requirement that you must report to those states, and so if you report now, external cause codes, so our E codes and ICD-9, if you're reporting those now, you'll continue to report those in ICD-10. It does go on to say that they do encourage us to voluntarily report those codes because they do provide that great data for injury research. Now moving on to the guidelines that talk about the 7th character in Chapter 20. As I said, the codes in Chapter 20 do require a 7th character, and they don't have that subdivision that we see in Chapter 19 when we're talking about fractures. So this is what we see right here, the A, the D, and the S, and that's pretty much all the options that we have. And they go on with the final bullet and tell us that we really want to match up our injury seventh characters with our external cause codes, and that makes perfect sense. They do tell us in 1C20A4 that we can assign as many external cause codes as necessary, and whatever we need as external cause to fully explain this case. And if only one external cause code can be recorded for some reason, then you would select the one that's most related to your principal diagnosis. Now, we do have combination external cause codes, and when we see something like this, it will identify sequential events. And so when you're trying to select a code for an injury, a good example here is a person who falls, and then after they fall or while they're falling, they strike against an object. And so that is one external cause code, and it takes all of that information and combines it into one code. There are situations when we do not need or should not assign external cause codes, and they tell us that no external cause codes from Chapter 20 would be needed if the intent is already identified in the code. So, for example, the codes in Chapter 19, when we're talking about poisonings, they already have the intent as a combination code there, whether it's accidental or self-harm, etc. So no additional external cause codes are utilized with those combination codes. Now, I mentioned Y92 and Y93 and Y99 codes for the place and the activity and the status, and we'll find that many of our guidelines for Chapter 20 do relate to these three categories. So let's take a look. We're going to start with place of occurrence. That's the Y92 code. Y92 code. That's your place of occurrence. Those are always secondary codes, and they would be used after I call the real external cause code. So what happened to this patient? Did they fall? Were they in an automobile accident? That's the true external cause code. And then I like to think of the place, the activity, and the status as kind of add-on codes, if you will. And so they go after the real external cause code. Generally, we assign only one, and it's only assigned at the initial encounter for treatment. Now, they did recently revise this guideline because folks had questions about, well, what happens when I can only assign one place of occurrence code, but now something has happened to the patient while an inpatient in the hospital, for example. So maybe they've had a fall from the bed. And so now they have revised this that says in rare instances, we could assign an additional place of occurrence code. It does tell us, maybe I should read that. I don't read the whole slides because you have these available to you, but maybe I should talk about the last bullet here. If we don't really have the place stated, and it's just not applicable, so we don't know where the person is, they do tell us just don't add on that Y92.9 code, which means unspecified. Now, you might ask me, well, why is the code even there then if I'm told in the guideline not to use it? To be a true classification system, we do have to have a way to classify everything. So that means unspecified codes. We do know we want to try to stay away from those unspecified codes when we can. So if it doesn't give any additional information, just don't assign it. In the states that require external cause codes, certainly if your state requires a place of occurrence, you would have to use that unspecified code. This guideline talks about the activity code, and you'll see a lot of similarities here. It's used only once at the initial encounter, Only one code from Y93 should be recorded, so they're telling us we can't really be doing two things at once. I like to joke a little bit and say they don't know moms or they don't know women, because I know a lot of times I do more than one thing at a time, but I guess we really shouldn't be doing that. And once again, they tell us these codes are not applicable to poisonings. Don't assign the unspecified activity if it's not stated in the record. And we can use this Y93 code with the true external cause code to identify the accident and the activity that was being done at the time of the event. Now, the place of occurrence and activity and status codes are to be used with other external cause codes, and I already talked about this. They are sequenced after that main external cause code, and as we said, only one place of occurrence, only one activity, and one external cause status code would be assigned unless we have that unusual circumstance that was accounted for in our place of occurrence guidelines. Now, this is quite interesting, and it is different from ICD-9, so you may want to make note of this, that if the intent of that injury or other condition is unknown or unspecified, that the intent defaults to accidental. And certainly all transport accidents are assumed to be accidental intent. Now, this is different, as I said, from ICD-9. And the only time that we use undetermined intent is when it's truly documented in the record that the intent cannot be determined. Sequela, we know, is the same as a late effect. The terminology in ICD-10 has pretty much changed to sequela, and sequela would be reported using the S. These codes should be used with any report of a late effect or sequela resulting from a previous injury. So there are even late effects or sequela for the external cause code, not for the place of occurrence or the activity or the status, but the true external cause code. So were you in an accident, automobile accident, did you fall, those types of codes. And now I've been talking about that external status, and so let's look at the guideline that pertains to that, and that is that guideline in the category Y99 that will indicate really who we are, who the patient is, and that can be assigned for any encounter. It always follows the true external cause code, and it is used in conjunction with the Y92 and the Y93 codes, and it's going to indicate the work status of the person at the time the event occurred. And so we have choices for military activity, non-military person who was working, other individuals, including students or volunteers, and certainly the external status code can be assigned with other external cause codes, as I said, and if it's not documented, they're also telling us that we do not need to use that unspecified code. And they are not applicable for poisonings as well. So some information about that. On this slide, we continue on with the guidelines. It does tell us that they're only for the initial encounter, and we only want one, only used once. And if we don't really know the status, the Y99.9 code doesn't really give us any good information. And so once again, unless it's required in your state, then it can be eliminated. Now, just kind of a recap, if you will, about those 4 external cause codes that I talked about. So, you might be wondering, what did she mean when she said the real external cause code? And that's what happened. What happened to this patient? And this particular picture is a person that's climbing a mountain and then fell. And so what happened? I like to think about if you get that phone call in the middle of the night and one of your children is out or one of your family members is gone somewhere, and the very first thing out of your mouth is, what happened? And then after you find out what happened, then you can go on into other details. Well, where were you and what were you doing? You might add on what were you thinking, but that's not part of the code set. Certainly we should know who they are, if they're working or not. So we don't have to ask that question, do we? Now, there was a really nice question in Coding Clinic, and I think you'll all like this question very much because the question was asked about the documentation that can be utilized for coding external cause codes. And so the answer was that the information must be contained in the official medical record. So it does have to be documented in the record, but it gets better. We can assign the codes based on physician documentation, but if the physician does not document this information, we can use documentation from non-physicians. That means from nursing documentation, from ambulance staff. And it does go on and clarify that if there's a conflict in that documentation, that the physician's documentation, of course, would take precedence. And that was a question in the first quarter of 2014 Coding Clinic. So if you have not seen that, you'll want to make note of this. This is great information for those external cause codes. So only the external cause codes that we've been talking about, no other information. And we can't really rejoice in this too much and start this with ICD-9 because it's not an ICD-9 guideline, right? Now, just a little bit more review on our 7th characters before we look at some cases. So one more time, if you will. Initial encounter, the patient's receiving that active treatment. Remember I said I like to think of active treatment. They're being actively treated with surgery or in the ER, or if they've gone to the ER and the fracture has been stabilized and now they're sent to an orthopod, and the orthopod is evaluating and providing treatment for that patient. Okay? Subsequent encounter is when we've had our active treatment and now we're just healing up and recovering. And the examples we've already discussed. So I'm going to move on to the next slide. And sequela is when we have something, a complication or a condition that results from an injury. And I know people struggle with sequela. It's probably one of the hardest things that we have to think about when we're coding injury. So after the whole injury is healed up, so you've made your last appointment, your orthopod says, I don't need to see you anymore. You're completely healed. And now something happens later after that injury is completely healed up. That's a sequela. And it does tell us in the guideline that we use both the injury code that caused it and then the code for the sequela itself. And the S will always go on our injury code, not on the sequela code. The specific type of sequela, for example, a scar would be sequenced first and then followed by the injury code. We have an example here of the correct coding and sequencing here. So this is a patient who was struck by a baseball. It caused a fracture of the orbit, and then after that fracture was healed up, they have a residual. So they have diplopia. So the diplopia is listed first to show what caused it. The fracture code listed second with the S. And remember that the real external cause code, so what happened, is always listed, either initial or subsequent or sequela, and so we also show that they were struck by a baseball. We don't see any place of occurrence or activity here because that's not appropriate with sequela. And this slide, I was asked to give some additional examples when I speak about sequela, because many times people can't think of complications from fractures. So what might we see as a sequela after a fracture as it's healed up? And I did do a little comparison here of subsequent, just to show us that in ICD-10, malunions and non-unions are considered to be subsequent care. In ICD-9, they're considered to be late effects, right? So we have a slightly different way to classify them in ICD-10 now. And then I just did kind of a list of some research that I did on different types of sequela after a fracture. So things like joint stiffness. I always use traumatic arthritis. It's the one I can always think of. But contractures certainly could be the cause, and then some of the infectious processes, avascular necrosis, osteomyelitis. Sometimes when fractures are at the growth plates in children, there can be growth disturbances and such. Now we're going to go over a few cases that were highlighted in that special issue. Well, it's not a special issue, but when we're talking about injuries and seventh characters, it's a special issue to me. So Coding Clinic for ICD-10 has been published now since the fourth quarter of 2012. But this was a wonderful issue that went through example after example after example of the correct assignment of seventh characters. And so I did use some of the context or concepts of this. You know, there is a copyright on Coding Clinic, so I couldn't put the exact case and the same answers that they had. So you'll see some of my cases that are similar to the cases in Coding Clinic, but they're not the same. So I certainly want to encourage you to go to that Coding Clinic and do a very careful review of all of their questions and answers. I think it's very important information. So our first case, we have an 8-year-old who comes to the ED. He fell due to a collision with another player. He was playing soccer. He was on the soccer field. He had a laceration on his right forearm, but no other injuries. The wound was cleaned. He had some small pebbles in the wound that were removed, and then they sutured it. The child is to be seen by the pediatrician within 2 to 3 days for a wound check, and the sutures will be removed in 7 to 10 days. So how do we code this encounter? Now, I'm going to put up the answers, and I know that I'm going to talk through this quicker than you can actually code this out. So what my advice would be for all of you is to practice the coding so that you can come up with the correct codes of these fractures and lacerations and so on and so forth. But what I'm going to be specifying or being specific on, and the purpose of doing this is to look at our seventh character. So yes, I'm going to give you the correct codes, or the codes that I feel are correct, but certainly you'll have time after the webinar to take this slower and actually come up with the codes yourself and have some practice on coding it. So we have this laceration, and I went with the S51.821, and our seventh character I selected was an A. So hopefully you all agree that this was an initial active treatment. He was seen in the ED, so that's active treatment. We go with the A here. There is a code for foreign body. In ICD-10, it is a combination code. I also coded the fall. So fall on the same level due to a collision with another person. And once again, we assign the seventh character to that code. That's our, like I say in quotes, real external cause code. It is an initial encounter. So W03. And then we have to fill in the 4th, 5th, and 6th position so that we get our A in the 7th position. So it's going to be W03, point, X, 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 and A. Now, if we are assigning the external cause codes, and the point of this webinar is to review some of those, so I am going to assign them all. Now, like I said, don't panic and think you have to assign these. If you do not assign them currently, you are not required to do that in ICD-10. But like we said, you're encouraged to do that. The place of occurrence is a soccer field. Why 92.322? What was he doing? Playing soccer. Why 93.66? And then who is he? He's not working. He's an 8-year-old child. He's not in the military, and so we'll go with other external cause status. And you can find that under your external cause index under recreation or sport, not for income or while a student, and it gives you the Y99.8 code. Of note, I just wanted to let you know that the whole concept of those complicated open wounds that you probably all have memorized in ICD-9, so showing whether there's a primary infection or foreign body or delayed healing or delayed treatment, that whole axis of classification has been eliminated in ICD-10. There are combination codes for foreign bodies like I showed you here. We can show if it's a fracture if we have delayed healing, but there's really no way to show for a laceration if there was delayed healing or delayed treatment. So a lot of that has just really gone away. It's not an axis of classification, as I said. The 7th character of A is appropriate because this was certainly an initial encounter, as we said. And the source of all of these will be the first quarter Coding Clinic 2015. So let's move to our second little scenario here. The same patient, so the same child, returns 2 days later as he was told for a wound check with a pediatrician. So the pediatrician takes a look, inspects the wound and looks for the healing. It looks like everything is healing correctly. There's no sign of infection. No other treatment is required. The mother is instructed to return in 5 days for the suture removal. So how are we going to code this? Are we going to use a Z code for aftercare? And I know you know the answer because I don't like Z codes for injuries, right? Because the guidelines tell us no. Guidelines tell us no for Z codes for injuries. So we're going to use the very same laceration code that we used before, but we changed what? We changed our 7th character. Instead of initial or active care, now the patient was given subsequent care. They were looking at the injury to make sure that it was healing correctly. We will assign our fall, the W03.XXX, and then a D for this one, and then we're finished. We don't assign the place and the activity and all of that because this is a subsequent encounter. Okay? Our third example, the same child, same little boy, comes back to the pediatrician's office for suture removal. The wound, of course, is checked and the sutures are removed. So can we use that Z48.02 code for an encounter for the removal of sutures? You might be tempted. You might be tempted, and you might wonder, well, why is that code even there if we're not allowed to use it? The code is there because other sutures could be taken out if a patient had a surgical procedure done, a gallbladder removed, for example. So something that is not an injury, then yes, we may need that code for aftercare for suture removal. But when we're talking about injuries, guidelines say no Z codes. So let's look at our answers. And I think you'll see that this looks exactly like the answer that we had on example 2. The laceration is the same code. We use a D. The fall is the same code. We use a D. And just a reminder that the guideline tells us no aftercare Z codes, and the aftercare and follow-up visits following treatment of the injury are captured with the seventh character of D. The coding clinic was very specific, and they said do not assign the Z48.02 code for encounter for removal of sutures. Now, I know that in the past, when we've done some training on ICD-10, we've suggested that, well, maybe this could be an add-on code. The coding clinic is saying, no, we don't assign it. So we're always learning, aren't we? Now, for example 4, we have a new patient. We have a 17-year-old male. He comes to the ED, so I'm sure you know the answer. He has a non-displaced segmental fracture of the left tibial shaft. He fell when he was tackled by another player on the field while playing football, and the fracture was stabilized in the ED. The patient was referred to the orthopedist for follow-up care. So how do we code this ED encounter? So here we have our answers, and once again, you can take the time to code this out. So a non-displaced segmental fracture of the shaft of the left tibia with initial encounter for a closed fracture would be S82.265A. And the fall is our regular or real, however you want to refer to it, external cause code, so the W03.XXXA. The place of occurrence is appropriate football field, Y92.321. Tackle football is Y93.61 for the activity. And then other external cause status, again, the Y99.8. And once again, you index that under recreation or sport, not for income or while a student. And I did want to clarify with all of you, just in case, and I'm presuming that you're familiar with the ICD-10-CM book, but just in case you are not, and we have some newer coders here, these external cause codes all are found in that special index, that separate index. Now, on example 5, we have the same patient. He arrives then to the orthopod, as he was told, for treatment of this non-displaced fracture of the shaft of the left tibia. The orthopod does some x-rays. He makes the plans for the ongoing care. He's going to put on the cast and arranges for follow-up in 4 weeks for a recheck. So how do we code the encounter with the orthopedist? The seventh character is going to be an A. So essentially the very same code. And the seventh character of A is assigned because the patient is still receiving active treatment of this fracture. The patient hadn't been seen by this orthopod. He had to do the x-rays, the planning of the care, and deciding what treatment the patient needed to undergo. And then, of course, we also assign the fall, just like we did. Okay, now we have the same patient. He's returning to the orthopedist's office after 4 weeks, as he was told. They see routine healing. The cast needs to be changed. Most likely had a follow-up x-ray, right? And they see that there's routine healing. The recommendation is to return in 2 weeks. Not quite ready to take the cast or the boot off yet. The mother informs the physician that they're moving out of state in 3 days and can't really return to this office. So the physician suggests a physician in a new area. Okay, so that's just a little piece of information about our next example. But we're still on example 6. How are we going to code this? So we have our fracture code, the S82.265, and we're going to move to a D because this is considered to be subsequent encounter. And we'll also assign that fall because of the collision with the D. And this would be routine care during the healing phase of the fracture. So cast change or removal is an example of subsequent treatment. Now, example 7, we have the same patient in our scenario who presents to that new orthopedist 2 weeks later, and the physician orders x-rays and determines that the left tibia shaft fracture is almost completely healed. He instructs the patient to return back now in 2 weeks to have the cast removed. So what do we think we're going to have for the answer here? The answer could almost go either way, and so what coding clinic has given us as the answer will be the 7th character of a D. They consider this to be a subsequent encounter. Also, then the fall can be coded with the D, and the answer is whether the subsequent visit is with the original orthopedist or a new orthopedist does not affect the assignment of the 7th character D. So the fact that the injury is receiving routine care during the healing phase is the determining factor. So this is a really great example to keep in mind when you're trying to make those decisions. Our last example is a new person. It's a 62-year-old male. He's status post-fracture of the right femur. He's admitted with intractable pain in the right hip. Now, the injury occurred around 12 months ago. Remember, there is no specific time period on when a late effect or a sequela has to happen. It could be sooner, it can be later, but this one just happened to be 12 months ago. He had previously undergone open reduction and internal fixation of the femoral neck fracture, and the diagnosis is traumatic arthritis of the hip, secondary to the femur fracture. Now, I gave you a hint, right? But this one's almost too easy, but I like to use an additional example from the previous ones that we looked at, just so that you get practice with this sequencing, because it does look quite different in ICD-10. So what do we sequence first? What the residual is now. What do we have now? Why are we at the physician's office? So the M12.551 for traumatic arthropathy of the right hip. You can find that under arthritis. That sends you then to arthropathy, traumatic. And in the ICD-10, the 1 at the end in the 6th position will identify the laterality. It will give us the right side. And then we also want to code what caused this, right? So we're going to code the S72.001, and we're going to use the S on that code, right? So the S always goes on the injury code. The traumatic arthritis is that sequela, or actually the late effect of the fracture, and it's identified by the injury code with the 7th character of the S. Now, if we knew the cause of this accident or how it happened, yes, we could use an external cause code. There really wasn't any information available in this example to assign the cause of that accident. Now we have a few cases to take a look at, and the same type of issue here. We'll read through the cases, and I will certainly give you the answers, and then as you're having more time, you may want to try to code these out for yourself. So this patient's being seen for routine healing aftercare of a right transverse femoral shaft fracture. So what code is assigned? And they tell us that it's during the routine healing aftercare. So the correct code is S72.321 with the D. So the D would identify that it's subsequent encounter for routine healing. The second example, we have a tarsus fracture of the distal right ulna. The patient fell from a ladder, and the patient's being seen now to remove an internal fixation device. So what 7th character are we going to pick here for the removal of an internal fixation device? That was one of the examples for subsequent. So our 7th character is going to be a D. For the fracture, the S52.621, and then D, and then the fall from a ladder is W11.XXX and D. So once again, we use those fill X's to make that a 7th character code. Our next shorter example, and then we'll get into a couple longer ones. This patient had a fracture of the left wrist. He's now being seen in physical therapy after his cast was removed. And once again, I mentioned that physical therapy, the rehab codes have been eliminated. We would not find any X codes that equate to that. Or I'm sorry, any Z codes. I'm sorry. I was thinking about those X's when we had the fill X's. We don't have any Z codes for physical therapy, so we code the fracture, and then we code that it is a subsequent encounter. So S62.102 and D. Here we have a female patient. She was a driver involved in an automobile accident. She was rear-ended by another car on the interstate highway, and she was seen in the ER complaining of pain in the arm and the neck. She was brought into the hospital by the EMTs on a backboard. They properly splinted the right arm. It was evident that there was a compound fracture present. She was treated for a displaced type 2 compound fracture of the shaft of the right radius and ulna, and she also received a collar for her cervical strain. So think about what injuries are going on here. The documentation that we have the type of open fracture, right? And by definition, the word compound means an open fracture. So let's look at our answers here. We actually have 2 fracture codes. It's quite interesting that there is no combination code for the ulna and radius, so we have to code those out separately. So fracture of the shaft of the right radius, and we're going to go with initial encounter for an open fracture, and the value of that is a B. If you think back on the slide that went through the fracture exercise that showed you what the 7th characters were for fractures. You can find this at the category level as well, so at the S52 category. And then the right ulna is S52.21 or 201B, sorry. And we have all of our 7th characters for the external cause code as well. So we have an additional injury, a strain of the neck, and so we would code that also with an A, so S16.1XXA, and then our external cause code, the driver of a car injured in a collision, V43.52XA. We can code that she was on an interstate highway as the place of occurrence, Y92.411. And that's really all I assigned here. We didn't really have any information about whether she was working or who she is, so I didn't assign a Y99 code. And we learned previously in the guideline that accidents are always have no activity assigned with them because the car driver is really the activity here, so it includes everything we need. Now, kind of looking at the rationale in this case, there was not a combination code for the fractures, as I said, so we code those separately. The type 2 open fracture, 7th character is a B, and the 7th character of A is used for the cervical strain. So that was a good example of having 2 different 7th characters available here, depending on the type of injury that we had. The Y93 category, as I said, we didn't assign because there's no particular activity stated, and there was no detail here. Certainly, if we had that information, we could add on a Y99 code as well. Case 5, we have a 60-year-old female. She fell down the icy front steps of her single-family home and sustained a non-displaced closed trimalleolar fracture of the medial and lateral malleolus of her left leg. She was brought to the ED and treated. I'm sure you're going to know the 7th character. She brought to the ED and treated, right? So it's all this other information we have to assign here. So she's at her home. It is a single-family home. quite specific. You may not see that in your documentation. If you do not, then we cannot presume it's single family. We would go with unspecified home. So let's take a look at some of the codes that we assigned for this case. The S82.855A would be the code for the fracture. We did go with the A. I'm sure you all figured that out because of the ED. Here's the fall due to ice and snow, W00.1 and then XXA. Y92.018 for single-family house, and Y99.8 for other external cause status. So the rationale of this is that the seventh character of A is used to indicate the initial episode of care for the fracture and fall. A code from the Y93 category would not be assigned here because there's really no applicable activity, and according to the guidelines, we would not want to use that Y93.9 unless it's required in your state. And then we did assign the Y99.8 because the patient was at her own home. Certainly, you can look in the record and see if there's additional information about being a work-related accident or not. And then finally, the resources that were used in this presentation. So the ICD-10-CM codes are available at NCHS website or at CMS website. The official coding guidelines are also available, and the references that I have to Coding Clinic are listed here. Some of the final cases came from the ICD-10-CM Coder Training Manual that AHIMA produces. And just a little note that the 2016 coding guidelines and the 2016 codes are available. The good news is that there is a note when you look at addenda for 2016 for the codes, and it's a very short statement that says there are no new codes for 2016 in ICD-10-CM. So at this point, I would like to conclude the presentation. Thank you very much for your attention.